everybody for coming. I hope you all are staying cool in this crazy heat. I'm extremely pleased to get to introduce Maggie Mott as our speaker today. I met Maggie this last year when she presented a really incredible talk at the International Society for the Study of Women's Sexual Health. And given the sophistication of the work that she presented, I was then quite shocked to find that she is not a full professor, but indeed a doctoral candidate in the Department of Pharmacology, Toxicology, and Neuroscience at LSU Health at Shreveport. In that talk, she presented some of the first work that's been conducted on the effects of methamphetamine on the dynamics of vaginal lubrication. And I believe she's going to be expanding a little bit on some of that today. Now, as a clinical scientist who is interested in women's health, I'm primarily interested in what her work means in terms of protecting sexual and reproductive health concerns in women who use methamphetamines, which is a rapidly growing population here in the Great Plains. There is increasing work to suggest that women are among the largest growing populations of meth users within the Midwest. So very, very important therein. But this important work also underscores a new avenue in understanding how meth and other stimulants interact with the peripheral nervous system at mucosal sites more broadly, which has really important implications for managing oral health in people who use meth. And anyone who's worked with folks who use meth know what devastating effects that use can have on oral health. So very, very important work in that respect. So in this way, Maggie's work really exemplifies what I think is the best kind of sex differences research, because it not only addresses the unique needs of females and women, but it also uses that uniqueness to build a stronger foundation of substance use research overall. I also note that in addition to being a basic scientist, Maggie's commitment to translation is evident in her leadership in a number of sexual medicine societies, even as a graduate student, and in her service on the board of directors of Loving Solutions, which is a Louisiana-based nonprofit that provides housing and recovery services for women with methamphetamine use disorder. So please join me in welcoming Maggie, and please feel free to put your questions into the Q&A. You should be able to see that at the bottom of your screen. There's a Q&A section, and note that that is a little bit different from the chat, which will be disabled. So if you have a question, please feel free to put it into the Q&A as we go along, but we'll also have that available to you at the end. So take it away, Maggie.
Well, thank you, Dr. Lorenz. That was probably the kindest introduction I've ever received. So it's very well appreciated. Well, thank you for the invitation, and thank you everyone for coming today. I really appreciate you being here, and I appreciate this opportunity. So today I'm going to talk to you a little bit about my dissertation research and build that into the basic science side of sex addiction. I have no disclosures. So as Dr. Lorenz said, my work focuses on methamphetamine, which is a potent psychostimulant and sympathomimetic. It's one of the most widely used illicit drugs in the world, but it only counts for 8% of admissions into substance abuse programs. It's the most commonly used drug of the amphetamine type stimulants, which includes drugs like MDMA. A recent national survey on drug use and health said that almost 1 million Americans had methamphetamine use disorder, and methamphetamine overdose-related deaths have increased almost 40% since 2014. It's unique in that it's used equally by men and by women, whereas all other illicit drugs are used more by men than by women. And methamphetamine also has lots of common comorbidities. Dr. Lorenz mentioned dental issues as one of them, malnourishment is another, but there's also some people don't often think of. 80% of meth users, meth users are 80% more likely to attempt suicide than abusers of other drugs. Meth users are 76% more likely to develop Parkinson's disease, and they're 80% more likely to contract viruses like HIV and hepatitis. So before we can understand, what meth does globally, I think we have to go down to the molecular level. So this is the mechanism of action of amphetamine, not methamphetamine, amphetamine. It induces the release of monoamines into the synapse. It inhibits the reuptake transporters, and it binds to monoamine oxidase to block the degradation. So what does this mean in terms of dopamine? So you guys may or may not have seen this figure before. It pops up every now and then. It shows the relative dopamine levels of male rat brains after crystal meth, morphine, and sex. Well, if you look at the paper that this is cited by, it's not quite right. This is actually the paper that it comes from. It was published in PNAS. It showed the percent of basal release of different drugs of abuse after sorry, I'm a little nervous for you guys, after different drugs of abuse. So you can see that on the left, in the nucleus accumbens, amphetamine increased the percent of basal release to 1,100%, which is what was showed in the last one, but that's amphetamine, not crystal meth. And you can see morphine on the right increased it to about 200. The closest thing that came to amphetamine was cocaine, which only increased to about 350%. So again, this is just amphetamine, not methamphetamine, but there's no other drugs that come close to increasing dopamine the way that amphetamine does. But methamphetamine also has this additional aspect to its mechanism of action, in that it reverses monoamine reuptake transporters. And that really makes a big difference when you compare amphetamine and methamphetamine. So this paper, which came out in the Journal of Biological Chemistry in 2009, shows that at lower concentrations, meth is more effective in releasing dopamine, which you can see in that bottom graph. It also showed that meth releases more dopamine from dopamine transporter transfected cells. And finally, it showed that meth is a more effective inhibitor of the dopamine transporter in vivo. So overall, meth is more effective at increasing synaptic levels of dopamine. And so I think that's really important to understand that, that one paper showed that amphetamine increases dopamine so much more than other drugs of abuse. And then we have methamphetamine, which increases dopamine even more than that. So I think that's really important to understand when we look at methamphetamine, because it's such a unique drug. And it's unique in some of its effects as well. So we've looked at it molecularly, and I think now we can look at it globally. Of course, you get the feeling of euphoria, which is the high, and you get increased energy. You also get decreased appetite, which is one of the reasons why women like to use the drug. And then you get teeth grinding and jaw clenching, which is one of the reasons why you have long-term dental problems. And then you get things like enlarged pupils, increased heart rate and blood pressure from the sympathomimetic effects of the drug. Long-term, the most important side effect, of course, is dependence, but you also get depression from this allostatic state downregulation that methamphetamine has caused. And I think that that's one thing that's one of the hardest to get back to. You also get things like paranoia, psychosis, and then, of course, almost any organ problem can come from it too. But women are affected by meth really uniquely. It appears from multiple sources that women are more dependent on meth. They are also more committed to meth, whereas whenever meth is not present, males will use other drugs instead of methamphetamine, where women would rather wait for methamphetamine. They have a lower age of first use, which means that these young girls are taking meth and they're damaging their growing brains more likely than men who are taking it, because their brains are not growing and maturing at the same rate. Women have reported experiencing meth-related problems at an overall greater severity than men. And they also have a significant psychological burden, because meth use often goes with trauma, and whether that be childhood trauma or current trauma, and frequently sexual trauma is an aspect of that as well. So we said sexual trauma, but there are sexual aspects to methamphetamine on its own. This one study looked at the sexual behavior in the past 6 months of 322 meth-using women. They looked at 4 domains, which were desire, pleasure, disinhibition, and sexual risk behavior. They saw that the desire for more frequent sex and prolonged sex was common. They reported things like marathon sex, and the only time women wanting that was when they were using the drug. They described intense pleasure as a key benefit of using the drug, and that being one of the reasons why they did not want to get off of the drug. Women said that their orgasms were better, and that some of them couldn't even orgasm without meth. Finally, they said a loss of inhibition was considered a positive experience. They were more willing to try things. They felt more confident. And as no surprise, they also had increased risky sexual behavior. So things like unprotected sex without using condoms, and more partners. As you can see in the table on the right, more partners was a big finding in their study. So we talk about these sexual effects. My mentor a few years ago started this interview-based study where he asked women, how does meth make you feel? He did not expect to get sexual answers, but that is what he got. So 88% of women who used the drug intravenously described a feeling indistinguishable from a physical orgasm, which is absolutely incredible to think about. That's never been found before, never been shared before in the research, in literature. So that's really important. And these same women also described a feeling of flushing starting in the chest and radiating downward to the genitals, and the production of excessive amounts of vaginal lubrication. 21% were told that using meth intravenously would induce an orgasm. They were told that by other women who used the drug. 28% of women mixed meth into a slurry, so basically as thick as would get through the needle. They wanted the highest dose possible. 45% reported feeling vapors or feeling it in their chest and then coughing whenever they used the drug. And they said that the vapors and the cough were a good sign that the drug was good. And finally, 52% reported intense paranoia. The most important thing, or not most important, the most interesting thing for me coming into graduate school of these was the vaginal lubrication. So I decided to attempt to make a rat model of methamphetamine-induced vaginal lubrication. But to do this, we first have to understand where vaginal lubrication comes from. So following sexual stimulation, neurogenic and endothelial release of nitric oxide, which I will talk about in great detail during this presentation, induces clitoral cavernosal artery and helicine arteriolar smooth muscle relaxation, which leads to a rise in clitoral cavernosal artery inflow and intracavernosal pressure. Then finally, there's a dramatic increase in capillary inflow in the submucosa, which overwhelms sodium reabsorption, and vaginal transudate is produced. It leaks out onto the inside of the vaginal walls as droplets of interstitial fluid. So to measure this in my rats, we knew, of course, they needed to be anesthetized. They would not let me do this when they were awake. So we use anesthetized adult rats under 9 months of age. We chose 9 months because 9 to 12 months is the perimenopausal period for rats. We pre-cleaned the vagina to remove any extraneous and basal fluids that were in the area to try and limit the weight that would be added to the swab. Meth was administered intravenously through a previously implanted chronic indwelling jugular catheter. After 5 minutes, the pre-weighed cotton tip swab was inserted using a small curved forceps as vaginal speculum. We tested saline and 7 doses of meth, and the rats were tested every 8 or 12 days. And this was to make sure that we limited irritation. You know, over a week is a good time to limit irritation, but also the rat's estrous cycle is 4 days. So allowing 8 or 12 days meant that each rat was in the same stage of its estrous cycle each time it was tested. So I'm in a pharmacology department. The very first thing I had to do when I started my dissertation project after I developed the model was to find dose response curve of methamphetamine-induced vaginal lubrication, which you see here. We tested doses up to 0.96 mg per kg. We saw that 2 doses were significant, and that was 0.12 and 0.24 milligrams per kilogram. I used 0.24 milligrams per kilogram for the rest of the experiments. And just for reference, in our self-administration studies, we used 0.06 mg per kg in our lab. So now that we had this clear identification that it was a real phenomenon in anesthetized rats, we wanted to test potential signaling molecules that could be playing a role in this. We started off with steroid hormones because they're so intimately linked with sexual arousal and desire. And so, no surprise, we started with estrogen. So it's the primary ovarian hormone implicated in the modulation of sexual desire and arousal. It's critical for the expression of female sexual behavior in many species, including monkeys and rodents. It can produce acute and chronic changes in moisture production, which makes it the first line treatment for women suffering from vaginal dryness, especially those that are postmenopausal. On its own, it's a potent vasodilator, but it also promotes nitric oxide production through various mechanisms like upregulating eNOS and nNOS expression. The next was progesterone. This one was not as straightforward, but we still wanted to test it. Its signaling in the medial amygdala is implicated in the sexual effects of meth. Meth-enhanced sexual motivation is partially dependent on progesterone in this brain region. And in the presence of ovarian hormones, meth facilitates activation of progestin receptors in this area. Finally, ovarian steroid response cells in the posterior dorsal medial amygdala show enhanced perceptive behaviors in rodents in the presence of meth. The last steroid we looked at was testosterone, which modulates sexual desire and arousal in women. It's the primary androgen regulating sexual desire and arousal in males. And it's currently being increasingly prescribed off-label for women with low libido, especially those postmenopausal. The mechanism for this isn't exactly known, but it's thought it could be peripheral aromatization of testosterone to estradiol. And one study found that testosterone and estradiol were required to maintain properly functioning machinery in the clitoris and possibly in the vaginal wall as well. Then we decided to look at nitric oxide, which I told you we would get back to. So nitric oxide is known as the neurotransmitter of sex, based on one researcher. I just love to include that because it shows the importance in this research. It comes from nerve fibers innervating the vaginal and clitoral tissues and from endothelial cells in the vaginal wall. It is the initiator of the vasodilation cascade, which I mentioned above, that leads to increased vaginal blood flow and vaginal lubrication. It has also been studied with meth in terms of excitotoxicity in the brain, but no one has ever looked at the sexual effects of the drugs together. So this is what we saw. I know it might look a little bit like confusing at first, but I just want to point out first, estradiol, which is the red line, we saw significant increases at 2 and 15 minutes post one infusion of methamphetamine, and progesterone, testosterone, and nitric oxide all increased significantly at 10 minutes. So just as a reminder, we were testing vaginal lubrication ending at 15 minutes. So all of these increases were before our 15-minute time point, which we find very interesting and told us that basically any of these could have to do with the phenomenon that we're looking at. But we thought the most important and possibly involved was nitric oxide, which again increased at 10 minutes. And it also showed the highest increase of all of the molecules we tested. To do this, we administered L-NAME, which is a non-specific nitric oxide synthase inhibitor, to the animals 10 minutes prior to methamphetamine administration. And then I gave methamphetamine and measured vaginal lubrication just as I shared before. And when we did this, we saw that, as you expect, saline plus saline treatment combination, you don't really see anything. When you give saline plus meth, we see this gross increase in lubrication production. L-NAME plus saline, we don't really see anything. And then the most interesting part was with L-NAME and meth, we see basically saline and saline levels, which told us that nitric oxide must be involved in this phenomenon. This is one of the most exciting findings of my graduate school career. I love this graph. I hope you guys like it as much as I do. But so this told us nitric oxide was involved, but we couldn't be sure that it was just nitric oxide. So we did the same thing with estradiol, which again increased at 2 and 15 minutes post meth infusion. We did the same method as we did with the nitric oxide. However, we used fulvestrant, which is an estrogen receptor antagonist. We administered the drug an hour before we did before we measured vaginal lubrication, because we had to administer it IP instead of IV. And when we look at this graph, it looks dramatically different than the one I just showed. So we see saline plus saline is one level, and fulvestrant plus saline, the third bar, looks very similar, which is to be expected. Vehicle plus meth increases, which again, to be expected. What's interesting is that fulvestrant plus meth did not decrease almost at all. It's almost exactly the same as vehicle plus meth, which tells us that it's really likely that estradiol is not involved in this phenomenon. So we tested all these signaling molecules, and we decided to test one more, which is VIP, vasoactive intestinal polypeptide. its innervation is heavily featured in the human vagina. Intravenous and subepithelial VIP injections in healthy women induce vaginal lubrication. And in animal models of female sexual function, VIP induces smooth muscle relaxation in the vagina. There have been studies linking meth and VIP. However, interestingly, these all have to do with vision, things like the optic nerve and the orbitofrontal cortex. So nothing like this previously. As with the other things we tested, we expected it to increase. However, as science happens, it did not increase, the blue line. It decreased dramatically from 1 minute to 45 minutes post-infusion, which is pretty incredible considering we expected an increase, but that's how science goes. We also, you can see here, we looked at corticosterone. We simply did that because the sympathetic effects of the drug and because our lab has been interested in stress since the late 1980s. So corticosterone is a common feature in this lab. So because VIP decreased, we assumed that it was not involved in this phenomenon. Now, the next factor of my dissertation came from, once again, this cascade. I told you all the blood flow changes that happen. It shows that blood flow is the single most important factor in increasing vaginal lubrication. More than the glands that are located around the vagina, it's blood flow. So I wanted to measure blood flow. After a few years, my school got the capabilities to do this, and I was very excited. So we used the Paraflux System 5000 with a small straight probe. It's a really simple procedure. It was inserted into the vaginal canal a few millimeters. And again, these were anesthetized rats. They were pre-treated with IV L-name, which is the same nitric oxide synthase inhibitor we used previously, or saline, and then treated with meth or saline. And this is the same treatment combinations as vaginal lubrication, so it's very similar. It's a great combination and comparison to look at. Here is a representative trace of an animal that received saline and meth. So with saline, you see no change in blood flow. And then when you give meth, you see this dramatic peak in blood flow, followed by a sustained decrease. The peak is what we expected from the increase in vaginal lubrication. You know, blood flow equals vaginal lubrication. And the decrease is what's expected from a sympathomimetic drug, all of the norepinephrine. So this was no surprise. It was exciting, but it was really no surprise. It was great to see something expected. When we gave L-name, we saw a quick decrease in blood flow followed by a sustained decrease in blood flow. And then when we gave meth, we did see a peak. It was smaller than what we saw with saline pretreatment. However, there was a peak. It never reached the level of blood flow before L-name, though. So it is possible that there's sort of a threshold blood flow level that's required to produce vaginal lubrication, and that maybe these animals don't reach that whenever L-name is on board. So these are just the pre-treatment, and this is perfusion units on the left. So this comes directly from the analysis that the program does. So you see saline and L-name pre-treatment was no change. Saline and L-name pre-treatment whenever saline was the treatment was no change. And then most interestingly, whenever saline was the pre-treatment and meth was the treatment, we saw this dramatic increase in blood flow. And this was significantly different than L-name by itself, as well as saline in the presence of saline and L-name. You can see all the way to the right, L-name plus meth did decrease. However, it didn't reach significance. I believe this is because there's so much natural variability in the amount of blood flow changes that occur in a rat's vagina that it's just not possible to always achieve this P is less than 0.05. But I do think that's an important decrease. So to summarize this part of my talk, I want to say that meth dose dependently produces vaginal lubrication in anesthetized rats. This lubrication is dependent on nitric oxide, but our studies suggest that it's not dependent on estrogen receptor signaling. Meth induces the release of signaling molecules associated with sexual arousal, like steroid hormones and nitric oxide. So we got that clear time course of these signaling molecules after one IV infusion of methamphetamine. Meth increases vaginal blood flow, which is required for the increases in lubrication that we've seen before. And this is also dependent on nitric oxide. So that's my brief rundown of my dissertation that I wanted to give to you guys. Now I'm going to switch gears a little bit. One question that I get asked every now and then is, you know, your project is interesting, but it's all about females. Where are the males? You know, where are the males? And the best answer I can give for that is you don't always have to study males to study science. It's not always about males. And when people press on, I just simply say that males don't have vaginas, so they're not a part of these studies. But whenever someone asks me this, it brings me to the next question, which is, what about females? So this is just a little timeline of the growth of females in clinical research. I'll mention just a few. In 1983, the Public Health Service Task Force on Women's Health advocated for more females in NIH-funded clinical trials and for more trials on female-affecting diseases. In 1990, a General Accounting Office study of the NIH grant applications found that 20% of applicants did not account for sex in their studies. And that doesn't mean that they didn't account for females. That means that they just didn't mention at all what sex they were using. Now, it's assumed that they were using males, but they didn't even mention what sex they were using. And finally, in 1993, the NIH Revitalization Act required the inclusion of women in clinical research. So we went from 1983 recommending, and then 1993 requiring. So it took 10 years to go from recommending to requiring, which I guess is not that long in science years, but whenever women are being neglected in science and in research, I think it's a long time. So that was in clinical research, but we have to look at basic science research. In May of 2014, this paper was published as a comment in Nature. And if you ever have a free 15 minutes, I recommend reading this 2-page paper. It's excellent, and it really changes the way you can look at sex as a variable. And again, they looked at sex as a biological variable. A brief rundown of what they said in the paper is, you know, despite half of NIH-funded clinical research trials being women, there hasn't been a similar evolution in how females are treated in basic science research, and that's cells and animal models, which is likely contributing to the rise in the lack of reproducibility of basic science studies. There are several quote unquote reasons why this is the case. I think the biggest of which is the convention of decades of research. You know, we do it this way because it's always been done this way. You know, things have been done one way for a long time, but that doesn't always mean it's the right way. There's also the lack of understanding of the magnitude of ignoring sex. And then the most common excuse whenever people say why they don't use females is because the estrous cycle induces too much variability into studies. However, this has been largely disproven in many studies, so it's not really a valid reason. It's really important to study females in the basic science sense because in clinical trials, it's seen that women experience more adverse effects of drugs, but these adverse effects are often not seen in preclinical trials, but it's likely because females aren't being treated the same way as males in these trials. And substance use is no exception. They actually mention substance use disorder in this paper. They gave the example that female rats exhibit greater responses to stress when norepinephrine is on board. And they say that a study published in 2014 provided the first evidence in humans that cocaine and ethanol craving and anxiety negative emotions could be decreased when they gave a drug that dampened the body's nervous system stress response. And what's important too in this NIH paper at the end, you know, they say these are our next steps. And it's to require applicants to report their plans for the balance of male and female cells and animals in preclinical studies in all future applications. And if they only use one or the other, it's important to validate why you are using one or the other. But that's all well and good, but there are scientific differences why males and females may experience things differently. So we know that that paper is important, but we also know that there are things that that paper cannot say in 2 pages. These are just a few of the reasons why males and females can differ whenever drugs are on board. The first is pharmacokinetics. That's a big one. You know, if a drug is more lipophilic, it's going to have a greater distribution in females because females have greater adipose stores. And the more lipophilic a drug is, the faster across the blood-brain barrier in general. You also have metabolism of drugs. So phase 1 enzymes like the superfamily of the cytochrome P450s, 2A6, which metabolizes nicotine, is more active in females, which means it has a shorter half-life in females. Nicotine has a shorter half-life, which means a woman may go smoke more than a male because it has a shorter half-life and she's trying to achieve that stable level of nicotine in her blood. Phase 2 enzymes are something similar. Males generally show faster clearance of drugs that are eliminated by glucuronidation. An example of this is oxazepam. So it's a prescription drug, but it's definitely a very abused drug as well. So these are really important pharmacokinetic implications to think of whenever we think of drugs of abuse and whenever we think of prescribing as well. Hormone signaling is also important. I'm going to go back to estradiol. Estrogen is noted to enhance reactions to rewarding stimuli and amplify the hedonic effects of psychostimulants, notably meth. And estradiol treatment increases positive subjective effects of amphetamine. And finally, we have neuroanatomical and neurofunctionality differences. Men have greater amphetamine-induced striatal dopamine release, but women develop thinner frontal cortices and have larger nucleus accumbens volumes after they use meth chronically. And they also show greater dependence and impulsivity, and it's been thought that these two are related. So now is usually when people would go on and on and on about lots of papers, but I'm only going to go over three that our lab has done that showed interesting sex differences. So this paper showed the paradigm of drug discrimination, which is used to determine the interoceptive effects of a drug in an animal. So it looked at the effects of 2 benzodiazepines, oxazepam and alprazolam, on the ability of an animal to recognize one injection of methamphetamine or cocaine. And you can see oxazepam on both methamphetamine and cocaine required a higher ED50, so a higher dose of the drug for 50% of the animals to respond than males did, which suggests that the females more strongly associate one injection of this drug with the discriminative stimulus of pushing the lever and recognizing what they have on their bodies. The second is from our IXT V100 methamphetamine vaccine study. METH-PRIMED reactivity is a relatively simple paradigm where animals are trained to self-administer a drug and then go through a period of abstinence. Before they're reintroduced to the self-administration chamber, they endure one IV or one injection of methamphetamine, so they're primed with meth before they re-enter the chamber. So you can see on the left, the dark circles are vehicle, the light circles are vaccine. You can see that there were similar responses in self-administration sessions in the males, as well as in the females on the right. And with meth reactivity, the males showed a gross decrease in responding with the vaccine. The females did not show this same decrease, which suggests a treatment like this vaccine or something similar may only be effective in males or may require a higher dose in females. And finally, the last paper that I wanted to show you from our lab is this one. So this is a 96-hour self-administration paradigm, which is what it sounds like. The animals self-administer drugs for 96 hours, and it very well models the binge and crash that a human user experiences when they use the drug. So you can see the bottom right, which is week 1 of, excuse me, which is week 1 of the female using the drug. She didn't start responding until a few days in, and she only responded for about 100 infusions, and she crashed for days. The male, on the other hand, the first week, he responded and had almost what we could consider crashes, but not quite long enough. Each of those tick marks is an infusion of drug. So he responded for about 500 infusions during this week. You can also see that he's responding on week 5, which is the top line. looks very similar to his responding on week 1. The general shape of the line didn't change, so he had a very consistent responding pattern. He did have 2 crashes. One crash was very early in the week, and the second crash was toward the end of the week. The female, on the other hand, she responded very, very consistently. Her responding did not look like her first week, obviously, and she had 1 crash. It was all the way at the end of the week. So she responded profoundly more than the male did. She reached almost 2,000 infusions. I believe that's 2,000. Yes, she reached almost 2,000 infusions, which is a lot of drug, to say the least. But this shows that even in drug taking patterns, males and females differ. You know, it looks like the male sort of loaded up and then had a crash, and then loaded and had a crash. The female continued to take it for a long time before she had a crash at all. Before I summarize this portion, I just wanted to show this table. I've been talking about sex differences in drugs of abuse, but there are also sex differences in drugs used to treat substance use disorder. I'm not going to go through all of them. Just for example, I see on the top is nicotine. For nicotine use disorder, nicotine replacement, bupropion, and topiramate are much more successful in men, and in women, varenicline, cholinergic, and noradrenergic agents are much more successful. So we see that, you know, I said nicotine. In women, nicotine has a shorter half-life. As I mentioned with 2A6, the cytochrome P450 enzyme has a shorter half-life, but this also shows us that that shorter half-life or anything else in the body could really be affecting what treatments are successful in treating these people. And finally, my summary is that drugs of abuse and substance use disorder treatments differentially affect males and females, and sex should always be treated as a biological variable. This is, I think, the most important point of my talk. It should always be treated as a biological variable. And it's been more addressed in clinical studies. However, preclinical studies are lagging behind. So if you do basic science, study more sex differences because it's really important. With that, I'll take any questions, and thank you for your time.